Hello students, today I want to discuss a very important topic, that is the peritoneum. So this is a very important topic which the students get confused whenever they study the abdomen. So I would like to highlight some of the important features of this peritoneum. This is Dr. Yusuf signing from Al Jof University. So these are the specific objectives which we will try to cover in this lecture. The first one is describe the vertical and horizontal dispositions of the peritoneum in both male and female. Second is identify the greater and lesser omentum, mesentery, mesoappendix, transverse mesocolon, sigmoid mesocolon, and other peritoneal folds with their contents. The third is identify the vesicouterine as well as the rectouterine pouches in females. The fourth is locate the rectovesical pouch in case of males. The fifth is identify the subphrenic spaces, paracolic gutters, peritoneal fossae, as well as mention their clinical importance. The sixth is identify the greater and lesser sacs of the peritoneum with their communication. The seventh is identify and locate the boundaries of the hepatorenal pouch of Morrison, or it is also called as the Morrison's pouch. And the eighth is describe the peritoneal relations of each organ of the GIT and explain its surgical importance. Okay, these are some of the specific objectives which we'll try to highlight in this lecture. So as you know, the peritoneum is a very important thin membrane which is a serous membrane, and it lines the whole of the abdominal cavity. So this is a large serous membrane lined by a single layer of flattened mesothelial cells and lining the abdominal cavity. So whenever you imagine the abdomen, within the abdomen you can find a thin membrane which will be completely lining the abdominal wall as well as the organs within the abdomen. So if you actually find this is actually a closed sac, even though in this picture it has been depicted that it is open, but actually it is not open, it is closed. Just imagine a balloon. Just I use this picture very oftenly whenever I try to explain the pleural cavity, where there is also a serous sac, as well as the pericardial cavity, which is also a serous sac, as well as the peritoneal cavity. All these cavities are having the similar concept of serous membrane, serous sac. Okay, and you can imagine this balloon. Okay, so this is the balloon. This is the similar kind of balloon, which is, you can imagine a balloon within the abdominal cavity, and the organs which are there, they are trying to invaginate into this balloon from all the sides. In case of the abdomen, it will be from the posterior side, from behind. Okay, so if you can imagine, if there is a balloon inside, deep inside, and all these organs are trying to invaginate into it. So they are not within the cavity, but they are outside the cavity, but try to invaginate. Just like in this picture, even though this person is punching into this balloon, but actually the fist is outside the balloon. It is not within the cavity. It is not inside this balloon, but it is outside this cavity, even though it is invaginating deep inside. Similarly, even these organs in the abdomen are invaginating into this closed cavity. So you should remember, this is a closed cavity, especially in case of males, and in case of female it is open, how I will explain you later. Okay, so actually imagine this as a closed cavity. Okay, so whenever you imagine a closed cavity, so all these organs are trying to invaginate. So they are not within the cavity, but they are invaginating, pushing into the cavity, just like this. Okay, so whenever you talk about the organs within the peritoneal cavity, they are not exactly inside the cavity, but they are still outside, lined by the the peritoneal fold. So this, whenever these organs try to invaginate into this cavity, they will form two layers, one which is in contact with the organ and the part with the part of the peritoneum which is outside. So whenever a organ is trying to invaginate, a part of the membrane is in contact with this organ. So this part of the the peritoneum, this will be called as the visceral peritoneum. So if you can imagine here, so here is the organ, one of the intestine is invaginating. So this is lined by a thin membrane, and this is called as the visceral peritoneum. The other outer one, which is not in contact with this organ, this will be called as the parietal peritoneum. Similarly, we have the parietal as well as the visceral pericardium as well as the pleura. Okay, so similarly here also, whenever it is in contact with the viscera, so that will be called as the visceral peritoneum. So this will be in contact with the viscera, so it will be called as the visceral peritoneum. So it is trying to invaginate inside. So it is a continuous, both this parietal and visceral, if you can imagine again here. So both these two membranes are continuous with each other. This is the parietal peritoneum and this is the visceral peritoneum. Both are continuous with each other because they are, as you can imagine, a single balloon with two layers. Okay. So this peritoneum is a closed cavity, just like a balloon inside the abdomen, and the organs are trying to invaginate into this peritoneum, and this will divide the peritoneum into an outer parietal layer which is in contact with the abdominal wall, anti-abdominal wall, and the visceral peritoneum, the inner will be the visceral, which will be in contact with the viscerous. Okay. So this is how the peritoneum is divided into two parts. So always imagine this balloon, and these organs are trying to invaginate inside it. Okay. So now, if you can see, now the organs can be divided into two types. One is the organ which is outside the peritoneum. Usually these organs are, in case of the abdomen, they are trying to invaginate from behind. Okay. So whenever they invaginate from behind, they take a layer of the peritoneum. This is the whole thing is the visceral layer. So they take a layer of the peritoneum and they will be hanging with a layer of the peritoneum. Okay. So these organs, even though they are not inside the cavity, they are called as intraperitoneal. So this is a misnomer. It is not, it should not be used as a intraperitoneal, because we have to differentiate it from the other type, which is retroperitoneal. So if you can see here, so there are two types of organs. One are which are behind the peritoneum. Retro means behind, so they are behind the peritoneum. Okay, and there are some organs which are invaginating inside the peritoneum layers. Okay, so these are called as intraperitoneal. Even though, as I said, it is not within the cavity, it is still outside the cavity, but it is lined by a thin membrane. Okay, just like as you have seen these pictures. So these organs are trying to invaginate inside. They are not inside the cavity, but they are lined. They are taking a layer of the peritoneum and they are lined by this layer of the peritoneum. So there are two types of organ. Some are behind the peritoneum. Those are called as the retroperitoneal. As you can imagine here, even though a part of this organ is still covered by the peritoneum. If you can see here, this is the pancreas, this is the duodenum. All are lined by a thin layer of the peritoneum in the front as well as even on the sides sometimes. Okay, so they are behind the peritoneum. Some organs are invaginating deep inside into the cavity. They try to invaginate, and they, along with them, they take a thin layer of the membrane and they will be hanging by this membrane, and this, whenever it covers the small intestine, then it will be called as it has a specific name called as the mesentery. So mesentery is nothing but a thin layer of the peritoneum by which this the small intestine is hanging. When it is covering the large intestine, then it will be called as the mesocolon. Okay. Sometimes initially the organs during development, they will be invaginating inside, deep inside, and they will have a mesentery. Later sometimes they again go back to their position back to the, especially to the posterior wall, and they lose this mesentery. Again they become the retroperitoneum. Now it is behind the peritoneum, so it is called as retroperitoneal. Here whenever it is having a mesentery, then it is called as intraperitoneal. And as I said, intraperitoneal is a misnomer. No organ is inside the cavity of the peritoneum except in case of female. We'll talk about that later. Okay. Now coming to the functions, once you understand the concept of the peritoneum as a thin membrane and a closed cavity, and into that the organs are invaginating, and by that they will be differentiated into the parietal and visceral peritoneum. And whenever the visceral peritoneum is there, it can have a thin membrane, and then it can form by which the organ might be hanging, and especially for the small intestine it will be called as mesentery, and in case of large intestine it will be called as mesocolon. Similarly we have the mesoappendix for the appendix. So coming to the functions of the peritoneum, the first one is it provides wet and smooth gliding surface which prevents friction. This is a very important concept, because whenever you respire, at that time, as you know, the dome of the diaphragm will be moving up and down. Whenever you inspire, the dome of diaphragm will come down, and whenever you expire, at that time it will be moving up. So whenever this dome of the diaphragm is moving up and down, at that time even the abdominal organs will be moving up and down. Similarly, whenever you have food, and whenever there will be digestion taking place within the intestine, at that time the intestine will be moving. They will be crumbling and crunching. Sometimes it makes sounds which you can hear even outside. Okay, so this is because of the movements which are taking place within the intestine. So the organs within the abdomen, this is just to indicate that the organs in the abdomen might be moving. So whenever they move, if there is when these organs will come in contact with some other organ, so they might have friction. Because of this movement, they might have friction when two organs come and meet each other. Now what the peritoneum does is it covers all the organs by this thin, wet as well as smooth membrane, and this, whenever these organs come in contact with this smooth surface with each other, they will be having no friction. They will prevent friction, and this prevents the inflammation between the organs whenever they are moving. So this provides a wet and smooth gliding surface which prevents friction between the organs whenever they move, either because of the respiration or because of the digestion or something else. Okay, so all this will be, the organs will be moving, and because they are covered, each organ is covered by, in the abdomen they are covered by a thin membrane of the peritoneum. So whenever the any two organs come in contact with each other, at that time when they start moving on each other, they will not have any friction because of the smooth gliding effect of the two layers of the peritoneum. And as you know, the peritoneal cavity will be filled with small quantity of even the serous fluid. This is a serous cavity, and it will be filled with very small quantity of serous fluid, almost 100 to 200 ml, which is normal. Okay, so this will be just acting like a buzzsaw within that, okay, in the abdomen. Second important function is it prevents spread of infection by greater omentum, which wraps an inflammatory organ. Especially this is very important, and because of this it acts as the policeman of the abdomen. This is called as the policeman of the abdomen. Peritoneum, especially the greater omentum. We'll talk about the greater omentum in a short while. So this greater omentum especially acts as the policeman, because it will have a huge quantity of macrophages, and this prevents, if there is any kind of infection which spreads to the abdomen, like in case of the ulcers. If there is a rupture of the ulcer, ulcers, peptic ulcers, if they rupture, there might be a small leakage of the quantity of food particles or some kind of infection. If it get inside the cavity of the peritoneum, at that time this immediately, especially this is seen in case of the appendix, if there is inflammation of the appendix, at that time especially this greater omentum will go and adhere and covers that particular part, and it all the macrophages which are within the layer of the peritoneum, they come and start fighting and they absorb, kill, do all the things, and this prevents the spread of infection. So if there is any kind of infection within the, if it is small in quantity, at that time this peritoneum with its huge quantity of macrophages will go and attack and decrease the inflammation, and this, by this it is called as the policeman of the abdomen. The third is secretes fluid rich in macrophages. As I said, it will be because of these macrophages as well as lymphocytes and other form of defensive mechanism will be present within the peritoneum. So this has the capacity to secrete rich fluid which is rich in macrophages, lymphocytes and other defensive mechanisms. So that's why this acts as the policeman of the abdomen. The fourth is it provides nutrition as well as innervation of the contained viscera by various peritoneal folds, and that latter has partial retention of the abdominal organs in its position. This is a very important concept. Whenever an organ is invaginating, it has to be provided with sufficient quantity of nutrition as well as innervation. So the two layers with which this peritoneum will be this organ will be invaginated into the peritoneum, between the two folds will be the passage of blood vessels as well as nerves. So the arteries will be passing through them, the veins will be draining through them, as well as the nerves will be passing inside. So this will give the passage for the especially the for the organs, especially for providing nutrition as well as innervation. We'll see that again. I will show you the pictures with which you can understand how the blood vessels will be passing through the two layers which will be covered by this organ, each organ. So this peritoneum provides a smooth passage for the all these vessels as well as nerves. And the fifth one is provides a surface area for absorption. So this peritoneum also has the capacity to absorb small quantity of fluid. As I said, there will be serous fluid. Apart from that, if there is excessive production of fluid because of some inflammation or something else, then if it is in small quantity, then it has the capacity to absorb. But if it goes beyond that, then it leads to a condition called as the we'll see ascites and other conditions where it will be too much. At that time it doesn't have the capacity. If it is in small quantity, it has the capacity, the ability to absorb and this is one of the functions of the peritoneum. Then it also has the capacity to excrete some of the waste products from blood, especially the urea, into the peritoneum. Then it also transfers oocytes within the peritoneal cavity. As I said, usually this peritoneal cavity is a closed cavity, but in case of females, except in case of females, it is an open cavity. And the only peritoneal, as I said before, there are no intraperitoneal, truly there are no intraperitoneal organs. Whenever we say intraperitoneal organs, they are just a misnomer because they are not within the cavity, but they are still outside the cavity. Except in case of female, the only organ which is intraperitoneal is the ovaries. So in case of female, it is an open cavity, it is not closed like in case of male. Okay, so this has again clinical importance. I will talk about that. Okay, so first understand this, that the only intraperitoneal organ which is present only in case of female, that is the ovaries. Okay, and a part of the fallopian tube. Okay, so whenever there is a release of oocyte, this will be the oocyte will be transferred from the ovary, released from the ovary, and it will be taken up by the infundibulum of the fallopian tube. So ovary as well as the infundibulum of the fallopian tube are the only part which are intraperitoneal. So the transfer of the oocyte will be taking place within the peritoneal cavity. So this is the a very important concept, and you should remember the only peritoneal, the intraperitoneal organ is the ovary and part of the fallopian tube, and this is only in case of the female. In case of male, it is closed. So the disadvantage of having this open cavity in females is especially the infections. Even though they are rare, but it is possible that some of the infections can be passed through the vagina or from the uterus and the fallopian tube into the cavity directly from outside to inside. So even though it is rare, but still it is possible. Since peritoneal cavity is an open sac in case of female, the latter may be occasionally victim of peritoneal infections from the exterior. As I said, through the exterior, even though it is rare, but it can pass from the exterior through the vagina, uterus as well as the fallopian tube into the cavity directly. So this is not possible in case of the male because it is a totally closed cavity in case of males. Now you can see here, this is how the whole of the cavity of the abdomen is lined. Even though it is a very simplified picture and there will be no cavity, such a huge cavity as shown in this, is just to show you, to make you understand how is the peritoneal cavity lining the abdominal wall. This is the parietal peritoneum, and what is in front of that, which is in contact with the abdominal wall, that will be called as the pre-peritoneal. And here in the posterior abdominal wall, whatever is behind the peritoneum, that will be called as the retroperitoneal. So all these are the extraperitoneal structures. Okay, either it is retroperitoneal when it is behind, and whenever it is in front of the peritoneum, then it is called as the preperitoneal. And here they have shown you a single part of the small part of the intestine, and here the peritoneum will be covering this part of especially the visceral peritoneum will be covering this whole organ, and it will be having this part of the organ will be hanging with a thin membrane, peritoneal membrane. This will be called as the mesentery in case of the small intestine, as well as it will be called as the mesocolon in case of the large intestine, or mesoappendix in case of the appendix. Similarly, we have sigmoid mesocolon is there. Similarly, there are many other particular names for particular part of the peritoneum. Okay, so here you can see here this is the organ which is invaginating, and it is lined by a thin layer of the membrane. This is the visceral peritoneum, and the other parts will be called as the parietal peritoneum. Now you should remember, this is called as the dorsal mesentery. Whenever the organs are invaginating from behind, this part is called as the dorsal mesentery. Okay, so this is the dorsal. Most of the organs in case of the abdominal are from the dorsal mesentery because they are coming invaginating into the peritoneum from behind. But except the liver, which will be invaginating from the front. This is only part where we have the ventral mesentery, where the liver will be invaginating into the peritoneum. So it will be also covered by the peritoneum. Now in this picture you can see the reflections of the peritoneum of the liver. This is the liver, and how the liver is covered by the peritoneum. So it is covered by the ventral mesentery, and this liver is completely covered by the peritoneum. You can see some of the remnants when you cut and remove the liver itself. The details have been discussed along with the study of the liver. So this is a part of the reflection which will be in contact with the anti-abdominal wall. This is called as the falciform ligament. Then below we can see the fissure of the ligamentum teres, as well as the fissure for the ligamentum venosum, as well as a part of the peritoneum which is around the porta hepatis. So all this, the whole part of this liver is covered by the peritoneum, except a few parts where we can see the reflections of the peritoneum. Okay, so here you can see here there is something called as the coronary ligament. So between the anterior coronary ligament as well as the posterior coronary ligament, there is a big area which is called as the Bayer area of the liver. whichever part of the liver is not covered by peritoneum, those parts are called as the bare areas of the liver. And the largest bare area is between the two coronary ligaments, anterior and posterior coronary ligament. This whole area is not covered by peritoneum, so it is called as bare, without any covering. Okay, so these two coronary ligaments meet at a particular point at the right side. This is called as the right triangular ligament. Similarly, we on the left side we have the left triangular ligament. Okay, and there is also small bare areas which are not covered by peritoneum, like where we have the inferior vena cava as well as the bed of the gallbladder, because it is covered, the peritoneum is covering the gallbladder itself, the inferior surface, so it cannot cover that part of the liver. Whenever you reflect, so that part of the liver will be bare. And even the porta hepatis, so this part of the, these are some of the parts of the liver which is not covered by the peritoneum. Okay, these areas are called as bare areas of the ear. Except these areas, all other parts of the liver are covered by the peritoneum, and you can see some of the reflections of the this peritoneum, like the falciform ligament, fissure of the ligamentum teres, fissure for the ligamentum venosum, as well as around the the portal triad. You can see also a thin layer of the membrane, and between the outside the bare areas, like the anterior coronary ligament as well as the posterior coronary ligament, right triangular ligament, left triangular ligament. All these are some of the reflections of the peritoneum on the liver. Here also you can see the liver, and here you can see the ascending colon and descending colon. These are not they are retroperitoneal organs. So both this ascending colon and descending colon are only covered by peritoneum in the front as well lateral side. But the small intestine, which will be having a mesentery, so this is the root of that mesentery which has been cut and removed. The whole of the small intestine has been removed, so you can see only the root of this mesentery. Okay. And similarly, you can see the root for this transverse mesocolon. Mesocolon, or the transverse mesocolon will be also a thin membrane of the peritoneum. So the transverse colon will have a mesentery which is called as the mesocolon. Okay, so you can see the root of this transverse mesocolon here, because the transverse colon itself has been removed. Okay, so whichever organs the intestine have the mesentery, they have been removed from their roots. So you can see the mesentery for the small intestine, then the mesentery which is called a mesocolon for the transverse colon. Similarly, even the sigmoid colon also has a mesentery that is called as the sigmoid mesocolon. So that part also has been removed. So whichever organ has a mesentery or the similar fold has been cut and removed in this picture. In the second picture, whichever organ has a or retroperitoneal, those organs have been removed. Especially you can see here the liver here, which is there, has been removed. So you can see, because this liver has a bare area, that part of the liver is showing as bare here. Okay, so here you can see the mesentery, the peritoneum, but you cannot see the peritoneum here because this part of the liver is bare. Similarly, the ascending colon and descending colon have been removed here, so you can see that part of the peritoneum is not there because they are retroperitoneum. So in this picture, retroperitoneal organs have been shown. Along with that, even here they have shown the pancreas as well as the duodenum and other structures like the kidneys, the right and left kidney. All these are retroperitoneal organs. Now let's discuss one more very important structure called as the lesser omentum. There are two structures called as the lesser omentum as well as the greater omentum. Let's see what is the lesser omentum, then we will go to the greater omentum. So this lesser omentum is nothing but a peritoneal fold which extends from the lesser curvature of the stomach to the first part of the, as well as the first part of the duodenum to the liver. So this whole thing, this is the lesser omentum. This is the thin membrane which extends from the lesser curvature of the stomach as well as the first 2 centimeters of the duodenum, the first part of the duodenum, to the liver. So this thin membrane extending from the stomach to the liver as well as from the duodenum to the liver. This is called as the lesser omentum. So because it is coming from two organs below, so it has two parts. One is the hepatogastric ligament. So this is the hepatogastric, which is coming from the liver and going to the stomach. Okay, then hepatoduodenal, which is coming from the duodenum and which is coming from the liver and going to the duodenum. So it has two parts, the hepatogastric as well as the hepatoduodenal ligament. Two parts of this lesser omentum. Okay. And there is a very important sac which is behind this lesser omentum. This is called as the lesser sac. Lesser sac. Sac means a cavity, so it is a blind cavity with a small opening here. This is called as the epiploic foramen. So it is covered, this cavity which is behind, which is called a lesser sac. It is a totally closed cavity with a blind opening, just one opening, single opening, which is through which it will be communicating with the greater sac. We will talk about that later. So this whole cavity is called as the greater sac. So here you can see here in this picture, this is a picture seen from side where you can imagine this. This is the lesser omentum, and this is the membrane, thin membrane, peritoneal membrane extending from the stomach to the duodenum, from the lesser curvature of the stomach to the as well as the duodenum to the liver. Sorry, so from the stomach as well as duodenum to the liver. So this is called as the lesser omentum. Just behind that there is the lesser sac, also called as the omental bursa. Why it is called so, we'll discuss that. Okay, this is called as the lesser sac. Sac is a cavity and lesser omentum is nothing but a thin membrane of the peritoneum. Okay, so it has two layers, the first and second layer, two layers are there. Okay, so this is about the lesser omentum. So lesser omentum extending from the liver to the stomach as well as from the liver to the first 2 centimeters of the duodenum. This thin membrane which has two layers, the first and the second layer, this is called as the lesser omentum. And behind this lesser omentum is the lesser sac. Okay, and this is also called as the omental bursa. And this omental bursa communicates outside with the greater sac through a small opening here. This is called as the epiploic foramen. Coming to the attachments. So inferiorly, the lesser curvature of the stomach and upper border of first 2 centimeters of the duodenum. We have already seen this is the lesser curvature of the stomach as well as the first 2 centimeters of the duodenum. This is the attachment below. So what is attachment above? As I said, it is attached to the liver in the form of inverted L. Inverted L. How it is attached? So it has a vertical limb as well as the horizontal limb. The vertical limb is the fissure for the ligamentum venosum. So it is extending from here. If you can see here, this is the liver. This has been reflected, so you can see the lesser omentum much more clearly. So as I said, it is in the form of inverted L. The vertical limb is from the fissure of the ligamentum venosum and the horizontal limb is from the porta hepatis, from the membrane around the porta hepatis. So this is called as reverse L. So this is how it is attached, even though in this picture you cannot clearly show, but by this picture you can easily imagine how exactly it is present in the form of inverted L with the vertical limb from the fissure of the ligamentum venosum and the horizontal limb from the porta hepatis. So that is how it is attached above, and below it is attached to the lesser curvature of the stomach as well as the first 2 centimeters of the duodenum. This is how the attachment of the lesser omentum is there. So this membrane between this liver and the stomach and the duodenum, this is called as the lesser omentum. Now there is something called as the greater omentum. So what is this greater omentum? So if you see this picture here, you can imagine, so this is a large fold of the peritoneum which suspends from the greater curvature of the stomach. So whichever is attached to the lesser curvature, that will be called as the lesser omentum, lesser curvature of the stomach, that will be called as the lesser omentum, which will be above here. It is behind this liver. If you reflect the liver, then you can see the lesser omentum above, and the whichever membrane is attached to the greater curvature of the stomach, that will be called as the greater omentum. It is also called as greater not only because it is attached to the greater curvature, but it is also greater in size. It is much more larger. Lesser omentum is smaller in size and greater omentum is larger in size. And this hangs like an apron from above downwards and covers all the loops of the intestine. So it is covering all the intestines. So all the intestines will be behind. So if you want to see the intestines, so you have to reflect this greater omentum only, then you can see the intestine. And this is having 4 layers of the peritoneum, which are fused together to form a fenestrated membrane having variable amount of fat. So this is a very important area where huge quantity of the fat is accumulated. So whenever you see a obesity in the abdomen, so this is because of the huge quantity of fat which is around this greater omentum. So whatever excessive food is absorbed, that will be stored in the form of fat, and this will be mostly, it will be here. It will be in other organs also, including liver, kidney and other things, but still this greater omentum is the major side where unabsorbed huge quantity of fat will be accumulated. And this membrane is 4 layers. I will show you the 4 layers, how they are formed. And this forms a partition between the supracholic and infracholic compartments of the greater sac. We'll talk about this. So how the 4 layers are there, if you can see, go back to this picture again. So we have seen that there are 2 layers for the lesser omentum. So 1 layer and a second layer. The first layer will cover the anterior surface of the stomach and goes down as the first layer of the greater omentum. The second layer, which was there for the lesser omentum, cover the posterior surface of the stomach, and it hangs from the greater, both the first layer and the second layer hang from the greater curvature of the stomach below downwards, and it goes to a large extent below and winds up. And these two layers will form the third and the fourth layer also. So the first layer becomes the fourth layer here, and the second layer, which is hanging down, then it winds back and this becomes the third layer. So the 2 layers which were there, now they become 4 because of the winding back of these first 2 layers into the third and the fourth layer. So the first layer becomes the fourth layer, then the second layer winds back to form the third layer. And they go above back and they go up to the anterior border of the pancreas. So here is the pancreas, which is a retroperitoneal organ, because only partly the peritoneum will be covered in this organ. So this 2 layers will go up to the anterior border, and the third layer will go above on the anterior surface of the pancreas, and the fourth layer will descend downwards, and then it covers the transverse colon, and this will be called as the transverse mesocolon. So it will be covering the transverse colon and form the transverse mesocolon. So whatever area which is above, that will be called as the supracholic compartment, and whichever is below, this will be called as the infracholic compartment. Now this layer, the fourth layer, will form the transverse mesocolon and then descend downwards on the duodenum. Most of the duodenum is retroperitoneal again, so it is behind the peritoneum. Now it descends downwards. Now this same layer will be forming mesentery for all these organs, because these organs are invaginating from behind, and they take a layer of this layer and they form a thin membrane, and through which they will be hanging. This will be called as the mesentery, especially for the small intestine. So they ascend to the anterior border of the pancreas, and the fourth layer covers the transverse colon to form the transverse mesocolon. So what are the contents of this 4 layers of the greater omentum, especially the first 2 layers? So the first 2 layers will have very important structures. As I said, within these layers will be the structures which will be supplying the organs as well as draining the organs, as well as the nerve supply, all passes through this two layers. So similarly, in the first two layers of this, because it is covering the stomach, so there will be blood vessels which are supplying the stomach, especially the right and left gastroepiploic vessels, which anastomose in the first two layers in the greater curvature. Below the greater curvature in the stomach, when I have explained the blood supply at that time, I told you in the lecture of this stomach that it will be supplied, especially the greater curvature of the stomach will be supplied by the right and left gastroepiploic vessels, especially the gastroepiploic arteries, and they will anastomose within this first two layers of the peritoneum. So it will be here between the first and the second layer. So in between the two layers will be this right and left gastroepiploic vessels. And the second important content of this Greater Omentum is one is these two blood vessels, and the second is huge quantity of fat which is accumulated within the abdomen, which is unabsorbed food materials which will be converted into fat and will be stored here, okay, for further use. Now coming to the functions of this Greater Omentum. So one is, as you can see, this becomes the storehouse of the fat within the abdomen. If you can see here, so this is the Greater Omentum, and you can see the huge quantity of fat which is accumulated as well as stored within this. Okay, so it acts as the storehouse of the fat. The second important function is protection of the peritoneal cavity against any infection. So along with the fat, this also has huge quantity of macrophages which are in the form of milky spots. There will be within this yellowish fat, there will be whitish spots. These are called as milky spots, and these are nothing but the aggregation of the macrophages. So whenever there is any kind of infection, as I told before, so there will be these macrophages will jump and attack the small quantity of infection, and they prevent any further infection, as well as they remove even this danger. So it helps in the protection of the peritoneal cavity. And the third important function is it limits the infection. So as I said, it attacked the infection, as well as a part of the peritoneum actually moves to the site of infection. So this is a very important function of the peritoneum, especially the Greater Omentum, that it moves, especially as I said in case of the inflamed appendix. So at that time, so this whole part of the peritoneum moves and it totally covers that, blocks that area. Okay, totally covers that part of the infected or the inflamed part, and it totally confines that infection to that region. So this is called the appendicular mass, okay, so which can be seen in later stages if the infection is not treated in the right time. So this is called as the policeman of the abdomen, especially the Greater Omentum acts as the policeman of the abdomen. So these are some of the functions. One is it stores a huge quantity of fat. The second is it protection with the macrophages which are present, and the third function is it actually moves and confines that infection to that particular region. So that's why it is called as the policeman of the abdomen. Now after studying the Greater Omentum and Lesser Omentum, now we'll go to the third important structure here, that is called as the lesser sac. So you should know the difference between the lesser omentum and the lesser sac. As I have told you, so this is the lesser omentum is nothing but the peritoneal fold which is in the lesser curvature of the stomach. Behind that there is a small cavity, and that is called as the lesser sac. It is also called as the omental bursa. So this is called as omental bursa because whenever the stomach want to expand, whenever you eat food and there is accumulation of food, as well as whenever the food is trying to digest the food particle, at that time the stomach moves and this small cavity acts as the bursa. So the function of the bursa, as you know, it prevents the friction again whenever the structure on over it will be moving. So this acts as a bursa, and that's why it is called as omental bursa. Okay, omentum means the gut, and the bursa, so because it acts as a bursa for the omentum, so that's why it is called as omental bursa. So it acts as a bursa to allow expansion of this stomach, as well as hence its name. Okay. So it is closed on, before I have told you that it is closed on all the sides except one opening, which is called the epiploic foramen. So it is a closed cavity except a blind sac. It is better to say in this fashion that it's a blind sac with only a single opening, which is opening toward the right side through a foramen, which is called the epiploic foramen. We have seen those pictures, and I will show you again those pictures later. Okay, so through which the the lesser sac will be, through the epiploic foramen will be this lesser sac will be opening into the greater sac. Greater sac is this whole cavity, the greater sac. Okay, so this whole cavity is the greater sac. So the lesser sac is a small cavity which is just behind the stomach and the lesser omentum. So it has to communicate with the greater sac through only one opening, which is called the epiploic foramen. So the boundaries of the sac, what are the boundaries of the sac? So it presents anterior and posterior wall. You can see the anterior wall here. So this is the sac, lesser sac. It has an anterior wall and a posterior wall. Then we have the four margins, which are those. One is the upper margin here, and the lower margin much below, and the right and the left margins. We will talk about that one by one. So what is anterior wall? So anterior wall, as you can see in this picture, so this is the anterior wall for this lesser sac. So it is formed by the caudate lobe of the liver. You can see this is the cross section of the abdomen, showing you the lesser sac. It is a small cavity, and in the front we have the stomach, as well as this is the lesser omentum, which you can see in this picture. So this is the lesser omentum, and here is the cavity, and the stomach is in the front. Similarly, you can see here the stomach as well as lesser omentum in the front, and here is the small cavity, small slate-like cavity. So the anterior wall is formed by the caudate lobe of the liver. Okay, so here you can see again. So the caudate lobe, a part of the liver, will be also forming the anterior wall. The caudate lobe of the liver, then the lesser omentum itself. This is the lesser omentum. So here also you can see the lesser omentum. Then the posterior wall of the stomach. So here you can see the stomach, and this is the posterior wall of the stomach, which will be forming anterior wall. Similarly, you can see in the cross section, this is the posterior wall. This is the anterior wall here, and this is the posterior wall. Behind that is this cavity. Okay, so these will be forming along with the two layers of the greater omentum. If you can see here, this is the greater omentum. The first two layers will be forming the anterior wall, and the posterior third and the fourth layer will form the posterior wall. So in between there is a cavity extending to a certain extent. So this cavity, which is the lesser sac, will extend beyond this, below here, up to here. So a part of the anterior two layers of the greater omentum also form the anterior wall of this lesser sac. The posterior wall, so you can see here, this is the posterior wall here. So here you can see that these are the structures which are in the posterior wall. So what are the structures? One is the structures of the stomach bed. All the structures which are forming the stomach bed will be forming the posterior wall, because the stomach is on the anterior side, and the posterior, these are the structures which are forming the stomach bed, and between this is the cavity. This is the lesser sac or the omental bursa. So all the structures which are forming the stomach bed, like the kidney, suprarenal glands, the aorta, and all those structures. Okay, along with that, the posterior two layers of the greater omentum. As I said, between the four layers, between the two layers, the first two layers and the last two layers is the cavity extending here. So the posterior two layers of the third and the fourth layer of the greater omentum form the posterior wall, along with the structures of the stomach bed. As I said, the kidney, suprarenal gland, aorta, all these structures will be forming the posterior, the stomach bed. So we have discussed the stomach bed in detail when we studied the stomach. So if somebody wants to know, they can go back to the lecture of the stomach. Coming to the left border. So the left border is very important border here. You can see in this picture also, this is the left border, and here is the right border. So the left border is totally closed, except we have the right border which is free, which is called the epiploic foramen. The left border is closed. How it is closed? By very important ligaments which are holding the spleen in its position. Okay, so here also you can see this is the spleen, and you can see these are the ligaments. Which are those ligaments? These are the gastrophrenic ligament, gastrosplenic ligament, as well as the lienorenal ligament. These are the three ligaments which we have discussed already when we studied the spleen. Okay, so these are three important ligaments which will be holding the spleen in its position. So these three ligaments will be forming the left border. Okay, so here you can see here this is the lienorenal ligament, which is also called as the splenorenal ligament. So in the front we can see the gastrosplenic ligament, and then we have the gastrophrenic ligament, which is going from the stomach to the diaphragm itself. So all these three ligaments will be blocking this area, and it will be closed. Okay, the left free margin of the greater omentum, even the greater omentum which is hanging down, which will be forming the left boundary. The lower border is again closed because the first two layers will continue as the third and the fourth layer. So here also it is closed. It is formed by the continuation of the second and third layer of the greater omentum at its lower margin. So the second layer will continue as the third layer, and it is closed down, and this forms the lower boundary for the this lesser sac. So the last or the final opening is the only opening is the epiploic foramen. So this is the opening through which this lesser sac will be communicating with the greater sac. So here in the whole of the abdomen it will communicating, that will be the greater sac. So this will be communicating only through the epiploic foramen. This is a very important structure in clinically. We'll talk about that later. Okay, so this is called as epiploic foramen, also called as the foramen of Winslow, as well as it is also called as the auditus to the lesser sac. Auditus is the opening to the lesser sac, so it is auditus to lesser sac, or it is also called as the omental foramen. Omental foramen. In this picture, if you see, it is mentioned as the omental foramen. So this is the only opening which is through which the lesser sac will be communicating with the greater sac. So it is the vertical opening through which the lesser sac communicates with the greater sac. So it is present behind the right free margin of the lesser omentum at the level of T12 vertebra. As I said, it is a very important clinical structure, so you have to know the exact position. So it cannot be identified with the moving structure, so it has to be identified always with a fixed structure, and fixed structures are mostly bones, and it is at the level of T12 vertebra. For the thorax and the abdomen, the most important fixed structures through which you can determine the exact position is by the vertebrae. So this is at the T12 vertebra. Now coming to the clinical condition, why it is so important that we are studying this epiploic foramen, because in case of strangulated internal hernia of the epiploic foramen, sometimes this lesser omentum is very important, as I said, because it is very close to the structures which are forming the stomach bed, and one of the structure which is forming the stomach bed is the pancreas. And sometimes the pancreas, because of the infection, or sometimes especially the carcinoma, then it can lead to some clinical condition, and there can be infection of this particular cavity, and there can be strangulation also of this epiploic foramen. This is called a strangulated internal hernia of the epiploic foramen. And if there is strangulation in this particular area, okay, so if there is a strangulation of this area, and that this epiploic foramen, it cannot be enlarged, even though it is strangulated and we had to open and start communicating the lesser sac with the greater sac, it cannot be done because very important structures are around this epiploic foramen. So clinically it is difficult to operate on this epiploic foramen because of important structures. So which are those important structures which are present in this epiploic foramen? So here very important structures which are present in the anterior are the the right free margin of the lesser omentum, contain the portal vein, hepatic artery, as well as the bile duct. All these three structures which are coming out from the liver are in the front. So all these three important structures are present in the anterior free margin of the lesser omentum. Okay, so you cannot operate in the front to open this epiploic foramen. Okay, so because all these important structures are there. So what is there in posterior? A very important structure is the inferior vena cava. If you can see in this picture, the inferior vena cava, as well as the right kidney, as well as the suprarenal gland, as well as the T12 vertebra itself. Okay, so there is a very small space, and that will be again having very important structures which can be damaged. So if you go superiorly, then there is the chordate process of the liver. So the liver has four important lobes, and one of the lobe is chordate lobe, and it has a process called as the chordate process. So it cannot be enlarged even at this particular superior border. So what about the inferior border? So the inferior border, again, it has very important part of the intestine, that is the first part of the duodenum, as well as the horizontal part of the hepatic artery is present within them. So that's why all these four boundaries of this epiploic foramen are having very important structures. So if there is any blockage at this epiploic foramen, or if there is internal strangulation within this because of the internal hernia in the epiploic foramen, then it cannot be opened up because of all the structures which are around, anterior, posterior, superior, as well as inferior. So you should be very careful when you are operating on this epiploic foramen. Okay, so this is the importance of this epiploic foramen. Now you can see here some of the structures which are within the layers. So I was talking about this that layers through this metal or the peritoneal folds. You can see within them there will be passage of structures which will be supplying this particular organs. So this will be giving a very smooth passage for the structures between the two layers of the peritoneum. Wherever they are there, they will be supplied by some important vessels which are between the layers, so they will easily pass through these layers and supply the organ as well as come out without affecting much of the other structures. Now coming to the fourth important structure after studying the lesser sac, now we are studying the greater sac. So the greater sac is this whole cavity, as I said. So lesser sac is here, which is small cavity, but the greater sac is, as the name indicates, it is a big cavity filled, which extends from all the way up from the diaphragm up to the pelvic floor, because the abdomen and the pelvis are continuous, and even the peritoneum will extend from the abdomen into the pelvis and to the pelvic organs. We'll talk about that. So this greater sac extend up to the pelvis, from the diaphragm up to the pelvis. This is the extent of the greater sac. So it extends from the diaphragm to pelvic floor and can be appreciated by tracing the peritoneum in vertical and transverse disposition. So you can trace this peritoneum, so it will be going all the way up to this the floor of the peritoneal cavity, the floor of the pelvic cavity. Okay, and it will be winding back upwards, even though there is a space shown which is quite big enough, but actually the space is filled with these intestines as well as the greater omentum. So there is actually no space at all. Okay, but to show diagrammatically, it has been shown with the space here. Okay, if not, it is filled with the intestine and other structures. So whenever the lesser sac communicates with the greater sac through the epiploic foramen, so this is the greater sac, which is cavity extending from the diaphragm up to the pelvic floor. Now after the lesser sac and greater sac, as well as lesser omentum and greater omentum, these are the four terminologies as well as the details we are studying. Now we'll go to one more important space. This is called as the hepato-renal pouch, or it is also called as the Morrison's pouch. So this is a very important pouch, because this is the most dependent part of the peritoneal cavity when the body is in supine position. So if you lie down on your back, then this is the most dependent part. Okay, so we have to trace it. Okay, why? Because if there is any kind of infection, or if there is any fluid, small quantity of fluid, so if you want to trace it, ask the person to lie down and trace this space, and if there is fluid, then this is the it indicates that there is fluid if you do with an ultrasound or if you pass a needle something. So you should be able to trace where exactly is this pouch. So where to trace this pouch? So the boundaries are superiorly the inferior coronary ligament of the liver. We have seen the superior and inferior coronary ligaments around the bare area. Below the bare area is the inferior coronary ligament. If you imagine this is the back of the person and here is the liver. So the person is lying, this is the lungs and this is the liver, and the person is lying on this back. Then you can trace it above. Superiorly we have the inferior coronary ligament, and inferiorly we have the right flexure of the colon. The colon will be present here. So here if you can imagine, this is from the other side. This is the picture seen from the right side, from the right lateral side. This is seen from the left lateral side. So here is the back, and you can see above is the inferior coronary ligament above, and inferiorly we have the right flexure of the colon. And the floor is formed by the kidney, anterior surface of the kidney. Here you can see here there is the kidney, and in between, so this is the space. So this is called as the hepatorenal pouch or recess also. So it is called as also called as the Morrison's pouch. Okay, so this is the space which is between the inferior coronary ligament of the liver above, and below we have the right flexure of the colon, and the floor is formed by the anterior surface of the right kidney. So this space is called as the Morrison's pouch, or it is also called as the hepatorenal pouch. Okay, why it is important? Because this is the most dependent part. If the person lies down on his back in the supine position, and if there is any kind of pus or fluid in the small quantity, then it will be collected into this region. Ask the person to lie down on the back and wait for a few minutes, then do a ultrasound or pass a needle, and if there is any kind of infection or pus, it will be easily seen through the ultrasound, or through the, you can drain it through the needle. Okay, so that's why clinically it is important. This is called as the hepatorenal pouch, because it is between the liver as well as the kidney. Okay, so that's why it is called as hepatorenal. Okay, now coming to one more important pouch. This is called as the rectouterine pouch, or it is also called as the pouch of Douglas. In case of male, this is called as the rectovesical, because there is no uterus in case of male, so it cannot be rectouterine, so it will be called as rectovesical. So this pouch of Douglas is the most dependent part when the person stands in erect position. So whenever the person stands, so this is the small pouch which is seen in the pelvic cavity. Okay, in the pelvis, because as I said, the abdomen and pelvis will communicate with each other, and the peritoneal fold which is coming from the abdomen, it even covers all these organs in the pelvis. Within the pelvic cavity, all these pelvic organs like the urinary bladder, the uterus, as well as the rectum, all these are covered by the same thin layer of peritoneum which is coming from the abdomen. Okay, so this pouch, which is called as the rectouterine pouch, the pouch of Douglas, or in case of male it is called a rectovesical pouch, is the most dependent part when the person stands in erect position. So clinically again it is important. If there is any kind of infection or pus or fluid, then if it is in small quantity, then ask the person to stand for some time and go and see within this pouch with the ultrasound, or put a needle into this pouch, and you can easily drain the fluid or the pus which is present here. And this is also the most dependent part when the person lies down in the supine position. So in the pelvic cavity, this is the most dependent part when the person lies down, but for the whole of the abdomen, this is the most dependent part when the person stands in erect position. Okay, so what are the boundaries of this? As the name itself indicates, anteriorly we have the uterus. This is the posterior wall of the uterus which form the anterior boundary, as well as it descend downwards as a thin fold of the peritoneum. This form the posterior fornix of the vagina. So here is the posterior fornix, this is the vagina, whole thing is the vagina, and here is the small space between the cervix and the posterior wall of the vagina. This is called as the fornix. This is posterior fornix, here is the anterior fornix. So this will be anteriorly we have the uterus, posterior wall of the uterus, as well as the posterior fornix of the vagina, which form the anterior wall for this pouch, and posteriorly we have the rectum. So here you can see in this picture, this is the rectum which form the posterior wall. So the space between the uterus as well as the rectum, this is called as the recto-uterine pouch. It is between the rectum and the uterus, so it is called as a recto-uterine pouch, or it is also called as the pouch of Douglas. But in case of the male, because the uterus is not there, so this organ will not be there, so it will be called as the rectovesical, because this is the urinary bladder, which is also called as the vesica. So it is between the rectum and the urinary bladder, so it is called as the rectovesical pouch in case of male, but in case of female it will be called as the recto-uterine pouch. So this is called as the recto-uterine pouch, or it is also called as the pouch of Douglas. And inferiorly there is a thin fold of the peritoneum, which is forming the rectovaginal fold of the peritoneum, which will be forming the floor of this pouch. So the applied aspects is, one is it is the most dependent part in erect posture, and if there is any kind of pus or fluid, then it will be collected when the person stands. So this can be easily drained because it is very close to the rectum, almost 5.5 centimeters from the anus. So you can put a needle from the anus and drain this pus into the anus, or the posterior fornix of the vagina. Through the posterior fornix of vagina, the pus can be drained here. So this is the pouch here, rectouterine pouch of Douglas. It can be, if there is any infection of pus, it can be drained into the rectum and the anus, or into the vagina by just putting a needle. So this is the importance of this pouch if there is any infection in the abdomen, and if it is in small quantity. Now coming to the divisions of the peritoneal cavity. So the peritoneal cavity is divided into actually three parts. One is called as the supracholic compartment and the infracholic compartment. Very important. This is the transverse colon. Whatever area is above the transverse colon as well as the transverse mesocolon, that will be called as the supracholic compartment. Whatever is below this is called as the infracholic compartment. Okay, again the supracholic compartment has many parts. We will not go into detail about that. So this is called as the right anterior intraperitoneal recess, right posterior intraperitoneal recess, right extraperitoneal space, left anterior intraperitoneal recess, left posterior intraperitoneal recess, as well as the left extraperitoneal space. All these are the parts of the which are around the liver and the kidney and other things. Okay, so we'll not go into details about this. This is in the supracholic compartment, which is above the transverse colon as well as the mesocolon. Below this space, below this transverse colon as well as mesocolon, that will be called as the infracholic compartment. Okay, and as I said, there is also third part. Some book mention as this third part is called as the paracholic gutters, which are on the sides of the ascending and transverse colon. Some books like this one will also include the paracholic gutters, the right and left paracholic gutters within the infracholic compartment, because it is below the transverse colon. Anyhow, it can be separated or it can be read as along with the infracholic compartment. So these are called as the paracholic gutters, which are beside the ascending colon and the descending colon. These are again important spaces where the fluid as well as pus can be collected. Okay. Now coming to the applied anatomy of the peritoneum as a whole. The first one is the most commonest, which is called as as well as very important, is the infection of the peritoneum as well as the inflammation. This is called as the peritonitis. So in case of peritonitis, if you feel the abdomen, usually whenever you palpate the abdomen, it will be soft and smooth. But in case of the peritonitis, because of the infection and inflammation, there will be anterior abdominal guarding, and this leads to a typical kind of rigidity called as the cardboard rigidity. Just like cardboard, this anti-abdominal wall, which was smooth and soft in consistency, now because of the peritonitis has become like a cardboard. So it is called as cardboard rigidity. And this kind of peritonitis, especially the generalized peritonitis, is very common, and especially this is seen in case of perforation of the peptic ulcers. Okay, whenever they are peptic ulcers, sometimes they undergo very rapid degeneration, and then there can be perforation of the peptic ulcers. Sometimes because of the rupture of the vermiform appendix, especially if there is gangrene of the vermiform appendix, then also it can lead to generalized peritonitis. But as I said before, the policemen of abdomen, especially the greater omentum, will go and cover, and it confines the infection to that particular region. And if that doesn't happen, then it will spread to the whole of the abdomen. This is called as generalized peritonitis, and this is especially seen in case of the perforated ulcers as well as the rupture of the gangrenous vermiform appendix, which is very common. The third important conditions associated with the peritoneum is called as ascites. As I said before, peritoneum is nothing but a thin membranous fold, serous membrane, and it is a serous cavity actually filled with small quantity of serous fluid. If it is up to 100 to 200 ml, it is normal, but if it is goes around 1.5 liters or above, then it leads to a condition called as ascites, where there will be huge quantity of fluid and this cannot be absorbed. As I said before, if there is small quantity of fluid, that will be also absorbed. The peritoneum itself has the capacity to absorb if there is small quantity of fluid. If it goes beyond this extent, if it is more than 1.5 liters or so, then this cannot be controlled, and this leads to a condition called as ascites. And this is a very common condition which is seen with the cirrhosis of the liver as well as the tuberculosis of the peritoneum itself, TB peritonitis. Then there might be congestive heart failure, which also lead to ascites as well as the malignancy. So these are four most commonest conditions where you can see the ascites is a common symptom. Okay, so whenever you see the ascites, a big belly filled with fluid, then you can imagine it might be because of the cirrhosis of the liver or TB peritonitis or the congestive heart failure or malignancy. These are the four commonest conditions. The peritoneum also forms a route by which metastatic spread of carcinoma takes place. So there are some infections in the, there are different routes of the carcinoma which can spread. It can be through the lymphatics, it can be through the blood, sometimes even through the peritoneum. So there are some infections which might travel from the pelvis to the stomach and beyond that, or sometimes the infections which are in the upper part of the abdomen might go into the pelvic cavity. So this is through the greater omentum and the peritoneum itself. So metastatic spread of the carcinoma can take place through the peritoneum. Then clinically, one more position is very important. This is called as the flus Fowler's position. Fowler's position. This is very commonly seen in case of the surgical department, wherever they do the any kind of surgical intervention into the abdomen. The patient will be asked to lie down at an angle of 45 degrees. This is to drain the any kind of peritoneal exudate and get it collected in the lower part of the pelvis. This is called as the Fowler's position. So after abdominal operation, the patient are usually placed propped up in bed with a backrest at an angle of 45 degree to allow the peritoneal exudate to collect in the pelvic peritoneum by gravity, and from there easily it can be drained through the pouch of Douglas into the rectum or into the posterior fornix of the vagina. Then if there is ascites, then they do something called the parasynthesis, or it is also called the peritoneal tapping, by which the fluid from the abdomen is drained outside. Okay. Then there might be also a condition called the pneumoperitoneum, where the air is filled in the abdomen within the peritoneal cavity, just like air in the pleural cavity can be filled. Then it leads to a condition called the pneumothorax, hydropneumothorax or the pneumothorax. So similarly, there can be a condition called as the pneumoperitoneum if there is air within the peritoneum. Then nowadays, and most of the surgeons, they go for the laparoscopy and laparotomy, where they do open up the abdomen, and actually they don't open, they just make small holes, and through which they see into the abdomen through small tubes. This is called a laparoscopy, as well as laparotomy, by which they do any kind of surgery and take out the surgically operated structures. Okay, so this is a condition where this small child has ascites, where the abdomen is filled with huge quantity of fluid, and that leads to a big belly here. Okay, so this is ascites, and if there is ascites, then they do, as I said, parasynthesis, or also called as the peritoneal tapping. This is the condition where they are doing the peritoneal tapping, where they are draining the fluid from the abdomen into a sealed cavity. Okay, then this is a condition where they are doing the surgery by thin tube. This is called the laparoscopic surgeries. This is especially done in the pelvis here in this picture, where it is called the pelvic laparoscopy, or it can be done in the abdominal laparoscopy also, where they put thin tubes with the cameras, with the guided cameras, as well as the surgical instruments through different tubes, and they see as well as operate on this. This is called the laparoscopy. And here you can see the peritoneal metastasis, which is on the surface of the liver, which is spreading through the peritoneum. Okay, so this is how there might be spread of infection, especially the carcinomas or the malignancies, and there might be metastasis through the peritoneum. So these are some of the clinical conditions which are very common with the peritoneum. So this is all about the peritoneum, and I thank especially the producers as well as the author of the clinical students Grace Anatomy, where I have used a lot of pictures from and usually use from most of the pictures from the students Grace, as well as some pictures from other textbooks, as well as even from the internet. I'm very thankful to them for to provide all these pictures, and I thank all of you for your patient listening. If you like this picture as well as this video, you can definitely click the like button, and if you want to get regular updates, as well as if you want to see more of these kind of videos which are related to anatomy, my videos, then you can definitely subscribe to my channel, and you can regularly get updated through my channel. Thank you very much.